And welcome to the brand new episode of Master Series session with our experts today. So today's topic of discussion is role of SGLT2 inhibitors in CKD. And our speaker for today is Dr. Bharat V. Shah. Welcome, sir.
Thank you. Thank you for this opportunity from Doc Plexus. It is uh, uh, it is my passion to educate people because education is the best way to create awareness.
Correct.
And
Sir, before you begin the session, I'll just quickly introduce you.
yeah,
So even though you do not require any introduction, I'm very sure of that. But Dr. Bharat V. Shah is the director of the Institute of Renal Sciences and Global Hospital, Mumbai. Also the General Secretary of ZTCC Mumbai, Managing Trustee at Narmada Kidney Foundation, and President of the Indian Society of Nephrology, West Zone. Dr. Shah has an experience of more than 35 years and has been the head of the renal and nephrology departments of several prominent hospitals in Mumbai. He's also authored many books and publications on kidney failure and transplants. Currently, he's working on a research project focused on renal disease and transplant. He's also the founder member and managing trustee of Narmada Kidney Foundation as well. And today's topic is suggested by the doctor himself about the role of SGLT2 in CKD. So over to you, sir.
thank you, Darshika, and good afternoon to everyone. The reason why I selected this topic is that after a long time we have got a drug which is likely to make big impact in management of people with kidney disease. In late 80s, we had ACE inhibitors and then we had angiotensin receptor blockers. These drugs had an important impact in management of patients with chronic kidney disease. Years we had no drug which came in the market. And it's after a long time we have got this drug which seems to be very promising, and I hope it serves the purpose of so many patients developing chronic kidney disease. So, what I plan to do today is tell you what is chronic kidney disease, what are the causes of chronic kidney disease. This is important because this is where you will realize that this new drug has an important role to play. What is the natural course of chronic kidney disease? How chronic kidney disease is treated? And having given you that background, I'll come to the main part of our discussion today, and that is the role of SGLT2 inhibitors in treatment of chronic kidney disease. So, as it happens with every organ of the body, there are two ways in which an organ can be affected. One is acute, which is sudden in onset, and another is chronic, which is slow and steady. So, if you have kidney abnormalities, which may or may not be associated with decrease in kidney function. By kidney function, I mean glomerular filtration rate. And by abnormalities, I mean the most common abnormality is persistent proteinuria and albuminuria. So if you have these abnormalities, or you have a persistently low glomerular filtration rate, less than 60 ml per minute, corrected to the surface area for more than 3 months, then it is called as chronic kidney disease. The important part of this definition is that it helps you to diagnose a chronic kidney problem even before your kidney function, that is your glomerular filtration rate, begins to decline. And if you identify at an early stage of just urinary abnormality, there is a lot that can be offered to the patient. And what are the causes of chronic kidney disease? You can see that number one cause is diabetes. Diabetes and high blood pressure account for more than 50% of cases of chronic kidney disease. And unfortunately, once one develops diabetic kidney disease, it is a progressive condition. It invariably progresses to end stage kidney disease. This is where SGLT2 inhibitor, about which I'm going to talk, has an important role to play. Then you have chronic glomerulonephritis, hereditary kidney disease. In about 5% of the cases, it may be due to stones, recurrent infections, and so on. And in about 20% of the cases, we have no idea what the cause is. Patients come to us at an advanced stage of chronic kidney disease because it's not uncommon for chronic kidney disease to remain a silent disease without any symptoms. So, what is the natural cause of chronic kidney disease? Chronic kidney disease, if not identified and treated early, it often, though not always, the most important thing that one must keep in mind that once you have identified a patient who has chronic kidney disease on the basis of persistent urinary abnormality or creatinine being persistently elevated, it is usually a progressive condition. And why is chronic kidney disease progressive? There are two main reasons. One is the persistence of underlying etiology. For example, someone who develops diabetic kidney disease, the patients often tell me, no, I am now keeping my diabetes under control. Why is my kidney disease progressing? You may keep your diabetes under control, but it is not like a normal person. There are fluctuations, there is variability. So that underlying etiology, which is persistent, will keep on causing progressive kidney damage. And therefore, one has to identify as early as possible. The second part is the adaptive changes that take place when the functioning kidney mass is substantially reduced. In late 1960s and 70s, there were reports where women who developed postpartum cortical necrosis. Cortical necrosis is due to a hypercoagulable condition. It is often patchy. So they do have, after the delivery, they do have a partial recovery and stabilize at a creatinine of 2 or 3 milligrams per deciliter. Now, there is no more hypercoagulable state, there is no coagulopathy, there is no underlying etiology, and yet these women went on to develop progressive decline in kidney function. Similarly, children who had a vesico-ureteral reflux and had damage to the kidneys, let us say that creatinine was 2 or 3 milligrams per deciliter, even after correction of reflux by reimplantation of ureters, they went on to have a progressive decline in kidney function. So why did the kidney function continue to decline even when the etiologic process was eradicated? This prompted researchers to carry out certain studies. So as I said, in 1970s, it was realized that chronic kidney disease continued to progress even when the etiology that caused initial kidney injury subsided. This prompted experimental studies in animals in whom the functioning kidney mass was reduced. So they took mice in whom 85% of the kidney was removed, 15% of normal kidney remained, but these kidneys continued to have a progressive decline in kidney function. So what did they find? They found that in each remaining nephron, there was an afferent arterial dilatation, efferent arteriolar constriction, so the glomerular capillary pressure increased, and in each remaining nephron, the glomerular filtration rate increased. So although the functioning kidney mass was only 15%, the glomerular filtration rate was still 25%. And this is called as an adaptive change. For example, if in your office, out of 10 people who are working, 7 people fall sick, the remaining three people will do more work in trying to complete the office work. So the remaining nephrons work more in trying to maintain the kidney function as close to normal as possible. These are called as adaptive changes. It was found that these adaptive changes were responsible for progressive decline in kidney function. So if these adaptive changes were minimized, the rate of decline in kidney function was slowed. And what are the measures to reduce the adaptive changes? In the early part, it was dietary protein restriction, and you all know that patients with chronic kidney disease are often advised dietary protein restriction. And then I mentioned to you that in 80s and 90s came ACE inhibitors and angiotensin receptor blockers. What these drugs do is they open up the efferent arteriole so that the glomerular capillary pressure is reduced, hyperfiltration is reduced, and that is how they help in reducing or retarding the rate of progression of kidney disease. So with this background, we now come to the role of SGLT2 inhibitors. In short, the role of SGLT2 inhibitors is also to minimize the adaptive changes. So SGLT2 inhibitors actually came into market for treatment of diabetes. And how do they help in treatment of diabetes? You know that normally when the blood sugar concentration is 180 milligram per deciliter, when it exceeds that amount, the glucose starts appearing in the urine. And that is the body's natural mechanism to prevent the blood sugars from rising to very high levels in the blood. SGLT2 inhibitors reduce the threshold and make glucose pass off in the urine even when the blood sugars are at a low level. So these drugs came into market for treatment of diabetes, but then it was realized that they are much more useful than achieving a better blood sugar control. So here you see the glomerulus, here you find the glomerular filtrate, glucose. Normally the glucose will be reabsorbed, but then these SGLT2 inhibitors block these SGLT2 receptors and allow the glucose to be lost in the urine. So what is the implication of glucose being lost in the urine? Glucose reabsorption is a function of sodium glucose cotransporter. So if the glucose is not reabsorbed, even the sodium is lost. So when the sodium is lost, a large amount of sodium reaches the distal tubule, that is the macula densa, and here it activates the tubuloglomerular feedback mechanism. What is the tubuloglomerular feedback mechanism? The tubuloglomerular feedback mechanism is that when there is more sodium reaching the distal tubule, there will be afferent arteriolar vasoconstriction. So when there is an afferent arteriolar vasoconstriction, the single nephron glomerular blood flow will decrease. And by decreasing the glomerular blood flow, it will decrease the glomerular capillary pressure and it will minimize the adaptive changes. So SGLT2 inhibitors act at the afferent arteriolar level. Angiotensin receptor blockers and ACE inhibitors act at the efferent arteriolar level, but they achieve the same purpose and both may be additive. So both of them contribute to minimize the adaptive changes. So this is one way that SGLT2 inhibitors help in minimizing the adaptive changes and thereby retarding the progression of kidney disease. By causing excessive natriuresis, they help in improving the blood pressure control, they help in reducing the proteinuria. All these factors help in retarding the rate of progression of kidney disease. So, which are the currently available SGLT2 inhibitors which are approved by FDA? So, currently we have empagliflozin, dapagliflozin, and canagliflozin. All these drugs have been found to be useful. They are given as a single dose. They achieve a peak plasma concentration within 1 to 2 hours. There is a good oral bioavailability. They are primarily glucuronized. The elimination is by hepatic and renal route, and all of them achieve a high amount of glucose excretion in a day. So let us see what have major clinical trials shown with the use of these medicines. So there was this canagliflozin and renal endpoint in diabetes with established nephropathic clinical evaluation, credence, CREDENCE, credence study, and let us see what it showed. This was a study to evaluate the efficacy and safety of canagliflozin 100 milligram versus placebo when used in addition to standard care of patients with chronic kidney disease and type 2 diabetes. The primary composite endpoints were doubling of serum creatinine. So, in how many patients creatinine doubled from 2 to 4? Time to dialysis of kidney transplant, how long it, in how many patients end-stage renal disease developed, and renal or cardiovascular deaths. The trial enrolled approximately 4,400 patients. The estimated glomerular filtration rate was 30 to 90 ml per minute, and all patients were on ACE inhibitors or angiotensin receptor blockers. Patients taking the drug had a 40% lower rate of composite renal endpoint, 40% eGFR reduction, renal replacement therapy or death compared with placebo. Then empagliflozin and progression of kidney disease in type 2 diabetes. Now you can see that they used 2 doses of empagliflozin, 10 milligrams and 25 milligrams. There was not much difference between these 2 doses, and this is placebo, and this is looking at the rate of decline in the glomerular filtration rate. So in placebo group, there was a constant rate of decline in the glomerular filtration rate over a period of 192 weeks. So almost 4 years of follow-up, there was a significant difference between empagliflozin group and the placebo. One interesting thing to observe is that initially when those adaptive changes are reduced or minimized, there will be a rapid drop in glomerular filtration rate. But thereafter, because of minimization of adaptive changes, further damage to the glomeruli is minimized and the kidney function remains stable for a long period of time. This is a very typical pattern seen with SGLT2 inhibitors, with angiotensin receptor blockers, and even with dietary protein restriction. Next, dapagliflozin in patients with chronic kidney disease. Again, a large number of patients with estimated GFR 25 to 75 ml per minute. And here again, the outcome was a composite of decline in GFR, end-stage kidney disease, or death from renal and cardiovascular outcome. Here, they included not only patients with diabetic kidney disease, but they included patients with non-diabetic kidney disease. And they found that among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of composite of a sustained decline in estimated GFR of at least 50% or doubling of creatinine and stage kidney disease or death from renal or cardiovascular causes was significantly lower with dapagliflozin than with placebo. And you can again see a similar curve, an initial rapid decline and then stabilization of kidney function. In the early studies, patients used were up to stage 3 of chronic kidney disease. Dapagliflozin was used even in patients with stage 4 chronic kidney disease. So in the same study group, there were patients who were in stage 4 and they looked at the outcome in those people and they found that even in stage 4, the curves were similar, just as in stage 2 and 3, there was a stabilization of kidney function. Even in stage 4, there was a beneficial effect of dapagliflozin. So all studies with all the currently available SGLT2 inhibitors have persistently shown a beneficial effect in retarding the rate of progression of kidney disease and possibly an even better effect in patients with diabetic kidney disease because inhibitors achieve better blood sugar control. We at our center looked at the efficacy of SGLT2 inhibitors in patients with diabetic kidney disease. This was an observational study. 102 patients with diabetic kidney disease and estimated creatinine clearance more than 30 ml per minute were included. 52 patients were on SGLT2 inhibition in addition to standard care, whereas 50 patients were on standard care alone. In both groups, standard antihypertensive therapy was used and the patients were regularly followed up for 12 months. Two important parameters were observed: progression of urine protein to creatinine ratio, which is a marker of proteinuria, and the decrease of estimated creatinine clearance. So you can see that the urine protein to creatinine ratio increased in those with SGLT2, in those who are not on SGLT2 inhibitors, and the protein to creatinine ratio remained stable in those who were on SGLT2 inhibitors. So there was a stabilization of proteinuria, and you know that proteinuria is an important marker, prognostic marker of progression of kidney disease. Same way, if you look at the glomerular filtration rate, the glomerular filtration rate continued to drop in patients who were on placebo, whereas the glomerular filtration rate, the rate of decline was significantly lower. It was 0.76 ml per minute per month in non-SGLT2 inhibitors group, whereas it was 0.45 ml per minute in the SGLT2 inhibitors group. So to summarize, chronic kidney disease is usually progressive due to underlying etiology and adaptive changes. Adaptive changes are in the form of efferent arteriolar vasodilatation, efferent arteriolar constriction, increased glomerular capillary pressure, and increased single nephron glomerular filtration rate. All these adaptive changes are minimized with use of SGLT2 inhibitors. They are an additive effect when used together with angiotensin II receptor blockers. SGLT2 inhibitors, by promoting natriuresis and tubuloglomerular feedback, cause vasoconstriction and minimize the adaptive changes. This helps in reduction of proteinuria and retarding the progression of chronic kidney disease. In diabetic patients with CKD, it also improves blood sugar control, which in turn also helps in retarding progression of chronic kidney disease, over and above the benefit of minimizing the adaptive change. Thank you, and I would like to leave some time for discussion because unless there is a discussion, it really does not help, and that's the only way to find out whether the audience has been able to understand the presentation that is made today. Thank you once again.
Thank you so much, Dr. Shah. Very wonderfully presented lecture. We've received a couple of queries and questions here, so we'll take those one by one.
I'll stop share.
Yeah, please. Sure. So my first question is from Dr. Srinivasalu Velumani. He says, what are the effects of SGLT2 inhibitors on other chronic diseases?
So SGLT2 inhibitors, actually you will see, was tried in patients with diabetes and cardiovascular disease.
Correct.
So there is a good, strong connection between diabetes, kidney disease, and cardiovascular disease. And in all major clinical trials, SGLT2 inhibitors not only benefited patients with chronic kidney disease, but they benefited also patients with cardiovascular disease.
Okay. My next question is from Dr. Mujib, who says, what are the 5 stages of chronic kidney disease?
Good.
I think you did mention that, yeah.
Yes. Now, this is only based on the glomerular filtration rate. So if you have urinary abnormalities like proteinuria and or hematuria, and your glomerular filtration is still normal, more than 90 ml per minute, corrected to surface area of 1.73 square meters, it is called as stage 1 of chronic kidney disease. When the GFR is between 60 and 90 ml per minute, it is called as stage 2 of chronic kidney disease. When the GFR is between 60 and 90 ml per minute, 30 and 60 ml per minute, it is called as stage 3 of chronic kidney disease. When the GFR is between 15 and 30 ml per minute, it is called as stage 4. And when it is less than 15 ml per minute, it is called as stage 5. But let me tell you, this stage alone does not prognosticate the chronic kidney disease. Extremely important is the presence of underlying etiology and the degree of proteinuria. To give you an example, if I have someone who has diabetic kidney disease, who has nephrotic range proteinuria, that means more than 3 grams of protein loss in a day, and even if that person has a glomerular filtration rate of 80 ml per minute, I am more worried. Prognostically, he is worse than if I have a 70-year-old man who is in stage 3 of chronic kidney disease, but has no diabetes, no hypertension, and has no proteinuria. So this man will never have a problem all through his life. He is in stage 3 of chronic kidney disease. The other person may be in stage 1 or 2 of chronic kidney disease, but in a short period of time, he will rapidly progress. So in prognosticating, the underlying etiology and degree of proteinuria is more important than just the stage of chronic kidney disease.
Sure. Another question. Now you talked about diabetic CKD patients. So can SGLT2 be also given to non-diabetic CKD patients? And if yes, what doses?
Exactly. So that is what I showed from the dapagliflozin study. Dapagliflozin study used not only diabetic CKD, but they also used non-diabetic CKD. And they were used in patients with stage 4 of chronic kidney disease also. That means those with a GFR of 15 to 30 ml per minute. And they were used in the same dose. The usual dose is 10 milligrams of dapagliflozin per day. And the dose kept was the same even for patients with stage 4 CKD.
Okay. And one last question. So SGLT2 inhibitors cause profound diuresis, which leads to fatigue and weakness. Though the drug claims to excrete glucose, only some electrolytes may be lost. So do we need an oral rehydration solution like an ORS or lemonade with salt every day?
So you know that most diabetic people are hypertensive. Most CKD people are also hypertensive. So actually it adds to our advantage. By
Okay.
causing natriuresis, they achieve some volume depletion, and volume depletion and volume access is the most important cause of hypertension in chronic kidney disease. So they don't cause a profound natriuresis and profound volume loss. Nevertheless, for people with good kidney function, we do advise them to maintain a good urine output and to do this, to maintain a good fluid intake. Now, this has another advantage. One of the possible complications of SGLT2 inhibitors is that by causing glucose loss in the urine, the risk of urinary tract infection is high. So when we tell them to drink plenty of water, the bladder is washed out frequently and the risk of urinary tract infection is reduced. So yes, for those with early stages of chronic kidney disease, we do advise them to drink more water because they lose more water by way of frequent urination, but it is not a big problem. You don't need to take some extra lemon juice or orange juice or extra juices. Just by increasing your water intake, you will be able to remain in fluid balance.
Sure, sir. So these were my questions. If you receive any more questions, I will definitely reach out to you and get these answers. So thank you so much, Dr. Shah. It is always a pleasure listening to you, and thank you for guiding DocPlexis as our, DocPlexis advisory league member as well. So we will definitely love to host you again very soon for such clinically read sessions. And until we see the audience again, please take care. And thank you so much for joining in. Thank you so much.
Thank you, Darshika.